Can we move to the next slide then? Thank you. I'd like to acknowledge my co-workers, Dr. Beena Gopinathan at Gawler Health Service and Angela Moffat, a Senior Specialist Ultrasonographer. Thank you. Next slide. I'd also acknowledge the encouragement and support offered to us at Gawler Hospital, South Australia by my colleagues, Faisal Chenia, Haroon Amin, Sonia Angus, our midwife, Sharon Hallett, also a midwife, Heather Holmes, our midwives, and our midwifery managers, and also the community and hospital midwives at Gawler Hospital, along with the Australian Institute of Ultrasound, who has been teaching them this technique. Next slide. The traditional management of labour is based on the discerning interpretation of clinical findings. Prolonged or arrest of labour is dependent on the serial digital evaluation of cervical dilatation, fetal head position, and fetal head station or descent, all of which have inherent inaccuracies and are subjective for a variety of reasons. Ultrasound has been promoted as a more accurate and reproducible method of determining fetal head position and fetal head station, and thus its use may serve to enhance the delivery outcome for women and their babies. At this point, serial ultrasound assessment of the cervix during labour has proven to be more problematic. May I have the next slide, please? The use of intrapartum ultrasound in labour management has gained momentum in the last decade, perhaps more so since the publication in the ISUOG guidelines, Intrapartum Ultrasound, by the following respected colleagues. Can we have the next slide, please? Currently, there is no consensus when intrapartum ultrasound should be performed, which parameters should be obtained, and how the sonographic findings can be integrated into the management of labour and delivery. This is a work in progress which we shall discuss and offer some direction. However, there is consensus that digital vaginal examination is often an uncomfortable and perhaps painful experience for many women, which may increase the chance of ascending infection of the fetus and chorioamnionitis and endometritis of the mother. Similarly, digital vaginal examination may even be more traumatic for those women with a fear of childbirth, previous traumatic vaginal birth, previous sexual trauma, and vaginismus. Next slide, please. Clinical trials are underway to give clinicians the required consensus. These trials have been coordinated in the UK by Kypros Nicolaides and Aris Papageorgiou, and in Europe by Jean Egbo, Boris Truchek, Wolfgang Henrich, Tullio G, and Giuseppe Rizzo. We're conducting a pilot study and trial at Gawler Hospital, which is a regional hospital, a rural hospital in South Australia, 55 kilometres north of Adelaide. Next slide, please. All clinicians will attest to the importance of determining the occiput position of the fetal head during labour. You as midwives would understand that, particularly the occipito-posterior position and its increased association with operative vaginal delivery and maternal and fetal complications, all of which you are aware. Similar precision is necessary in determining fetal station and ensuring correct application of the nominated instruments if required to minimise the occurrence of a failed assisted vaginal delivery and the consequences of a caesarean section at full cervical dilatation with its well-documented increased maternal and fetal morbidity. Next slide. Even experienced clinicians, including yourselves, if completely honest with their recall, will not be surprised to learn that digital determination of fetal head position may be inaccurate, ranging from 20 to up to 70% error if ultrasound determination of fetal head position is used as the gold standard. This is more so particularly with occipito-transverse and occipito-posterior positions where associated deflection, asynclitism, caput and moulding may influence the accuracy of the clinical assessment. These positions, of course, are the very circumstances where obstetric assistance is often required. Next slide. So how do we organise the fetal head position? This is best determined by transabdominal imaging, placing an abdominal ultrasound probe transversely on the maternal abdomen at the level of the fetal abdomen or chest, where the position of the fetal spine may be determined. The probe is then moved downwards to the maternal suprapubic region to identify the fetal head. The fetal occiput can be best determined by identifying the thalamus and midbrain structures with the characteristic arrow sign pointing to the position of the occiput. You may be also able to see the fetal orbits in the occipito-posterior position. Can we have the next slide? It'll show it for us. There we are. So if you look at the, this is the window here. This is the arrow sign pointing to the occiput. So we know under those circumstances it's left occipito-transverse. And here is pointing to the right. It's right occipito-transverse. Thank you. Next slide. So this is direct occipito-posterior, and here you can see the orbits. And once again, similarly here, and this is looking at a left occipito-posterior position. So using the ultrasound landmarks as an adjunct to clinical examination, the following positions should be able to be more accurately determined: OA, OT, OP, and confirmation by transabdominal identification of the fetal spine is often very helpful. Next slide, thanks. With occipito-anterior position, particularly with a deeply engaged fetal head, the fetal spine can be demonstrated in the longitudinal plane by transabdominal scanning and traced from the fetal thorax down to the occiput. Under these circumstances, the cervix is impossible to see due to the shadowing from the skull. That's in our first image, which we'll have in a minute. But the thalamus can be seen in the second image and the head position can be determined. Can we have the next slide, please? Thank you. Here we are, is our initial slide. It's very hard to determine where the cervix is, but here we can see the position by looking at the arrow sign, which tells us that this baby is probably in the occipito-transverse position. Next slide, thanks. So the fetal head station. This refers to the level of the fetal head in the birth canal in relation to the maternal ischial spines. Digital vaginal examination is being designated as being engaged if the maximum diameter of the fetal head, the BPD, has passed through the pelvic inlet, which should also be assessed by abdominal palpation where there's less than 2/5 of the fetal head palpable. As a matter of fact, you would always probably say 1/5 or not at all when the leading part of the fetal head has reached the level of the maternal ischial spines of the maternal bony pelvis. This is expressed as station 0. We have the next slide, please. Of course, these are all very familiar to you, and so we'll continue on with the next slide if we may. It's a clinical assessment. The higher fetal head station expressed in centimetres above ischial spines, lower fetal head station expressed in centimetres below the ischial spines. There is confusion in some centres in determining the leading part of the fetal head. Is this the fetal skull just palpable at the level of the ischial spines, or must the biparietal diameter be at the level of ischial spines? So generally, clinicians work out a compromise with the fetal head station, and this is why we have inter-observer variation, I believe. We have the next slide, please. These variables, plus the presence of deflection, asynclitism, caput and moulding, have made the assessment of fetal head station particularly subjective. This problem has been confirmed by elegant sensor stimulation studies by Dubois, who've demonstrated a mean category area for trainee obstetricians, consultant obstetricians, and I'll just go through this quickly because I'm conscious of the time. Overall, with combined digital vaginal examination and abdominal palpation, we showed at least a 30 to 34% error in the assessment of both fetal head position and fetal head station. It's a little bit discerning, isn't it? Or disappointing. Can we have the next slide, please? Okay, so hence in summary, intrapartum ultrasound can determine or help determine fetal head position and fetal head station more accurately with minimal intra and inter-observer variability. Accurate determination of fetal head position and fetal head station is important in determining progress in labour, particularly in the second stage, and is important when assessing the suitability for the likelihood of success of operative vaginal delivery, OVD. Can we go to the next slide, please? So can I talk to you a little bit about the mechanism of labour? As you know, the fetal head travels through the birth canal. It descends initially in a downwards direction and changes direction to a horizontal direction, then finally travels in an upward direction along with rotation as the fetal head comes into contact with the pelvic floor and the levator ani. Simple things that you all know. Hence, there is a need for measurements that follow the curvature of the birth canal, the curve of Caris. However, the abdominal ultrasound cannot identify ischial spines, which is a critical landmark on digital examination to determine the centre of the presenting part. Well, how do we get around this? Well, we can overcome this by using CT bony pelvis scanning and urogynecological anatomical markers to determine the infrapelvic or infrapubic line, which can be drawn from the pubic symphysis vertically to the sacral curve. And it's been consistently that the ischial spines are 3 centimetres below this line. Can we have the next slide, please? So here it is as a CT of the pelvis. We can see the ischial spines here clearly. Please move to the next slide. This is a lateral view. You can see the symphysis pubis here and the infrapubic line back to the sacrum. 3 centimetres below that, you'll find ischial spines. And here we are. Next slide. And as you can determine, also we're able to work out the level of axis of the symphysis, infrapubic line, 3 centimetres below level of ischial spines. Next slide, please. This, in relation to the fetal head, can give us some indication as to where we are in relation to the station of the head. In this case, it's just at the level of ischial spines. Next slide. Also, we can determine the direction. So if we've got descent, we know that's the early part in the second stage. If we've got transverse, we know that that's the mid part of the second stage. And if we've got elevation or upward direction, then we know that this is starting to be delivered or delivering. The baby will deliver this way. Can I have the next slide, please? So here we are, a composite slide with the head well below the ischial spines, or the level of the ischial spine, which is 3 centimetres further down from this particular. Here's the infrapubic line. Here's the line for the ischial spines. And here's the head well past that in an upwards direction, about to deliver. Next slide. All of this, of course, you can see on your ultrasound. If you want to determine how close the head is to the perineum, you can also do the head-perineum distance, which I'll spend a little bit more time on in a minute. Please, next slide, please. The angle of progression or the angle of descent is probably the most critical measurement that we can do. It's held by transperineal scanning. It's held just gently against the introitus with the probe in the longitudinal position. Okay, please have the next slide. So here's in position. If we want to do the head perineal distance, we put the probe transversely and do it that way, but I'll explain that in a minute. Can we go back to this one? Next slide, please. So the fetal head stage is best performed by transperineal ultrasound, as I've said. The probe is covered with a glove or plastic sleeve with a marker in the anterior position, gel applied. The probe is placed between the labia majora, more caudally at the level of the fourchette, with the women in the semi-recumbent position with legs flexed at the hips. It's essential that the bladder is empty, and in the longitudinal plane, the following landmarks are clearly depicted with minimal, if any, pressure against the vulva. This is why it's so acceptable to the patient, as distinct from invading her with a digital vaginal examination. Next slide, please. So we can identify the pubic symphysis, which is an oblong, irregular echogenic structure, and also the fetal skull. The ischial spines cannot be visualised, as I explained previously. But we know that there's a fixed anatomical relationship with these spines being 3 centimetres below. Can we go on to the next slide, please? May we have the next slide, please? Thank you. This is a composite slide. This shows us the angle of progression, which is taken from the symphysis pubis to the skull. If this is greater than 120 degrees, which this is, then we're very confident that the baby will deliver, either spontaneously or with some assistance. Here, of course, is the ischial spines at this level, and you can see the head is already past the ischial spines and is proceeding in an upward direction. So you're pretty confident that this is going to deliver, this baby will deliver normally. Carry on. Next slide. So the angle of progression, as I said, is the angle between the long axis of pubic bone, a line drawn from the lowest edge of the pubic symphysis, tangentially to the deepest bony part of the fetal skull. Tuchek compared the angle of progression and transperineal head station and found that the fetal head station of 0, level ischial spine, corresponded to an angle of progression of 116 degrees. We're a little bit more liberal, and we look at about 120 degrees to be able to be more confident. I'll explain this in a minute. It's predictable, usually, of spontaneous delivery. Fetal head direction is also very helpful. So you look at head downwards, head horizontal, or head upwards, and it gives you some prediction. So can we go ahead, please? Next slide. Thank you. So this is the angle of progression. As you can see, as the head is just reaching ischial spines, it's about 120 degrees. It's a little further on here, and here it is 212 degrees as the head's moving out. So these are the angles of progression that
Dr. John, we can't hear you. Are you still there? Can anybody hear you? Dr. John, we can't hear you, please.
அவங்களே மியூட் பண்ணலாம்.
Giving a few minutes to arrange problem and coming.
Hello.
Oh. That's sad. We lost him.
Can you hear me now?
Yes, yes, we can hear you. Go ahead. Thank you.
Sorry, I don't know what's happened there. Are we able to return to the lecture or not?
Please run up.
It's run out?
Yeah, complete your presentation.
Okay, all right. Well, I give my apologies to everyone, and I'm sorry to have done that to you and taken up your time. Do you want me to leave now?
Go ahead, please complete your presentation in 2 minutes.
All right. Well, I don't think I can do it in 2 minutes, but I'll try. So we're looking at the angular progression, and we're able to tell at the station of 0, it's about 116, 120. Next slide, please. And when it's plus 2, it's over about 140. So we get this idea of 100 degrees, that means it's above ischial spines. 120, it's the level of ischial spines. 140, it's well below ischial spines. So that's the beauty of it. Can please proceed? Next slide. By simply rotating the transducer through 90 degrees, we can then get on to the additional parameter, which is the head perineum distance. You need an empty bladder. Can we next slide, please? Next slide. We'll skip over that slide. So the bladder must be empty before proceeding, and here's what we get. We can see the head skull here, perineum there, and this distance is the critical distance, head perineum distance. Can we have the next slide, please? And this shows that when you're further back from the perineum, and as you get closer, obviously the distancing decreases. Next slide. You can even see caput and moulding as well when you're doing this assessment. So it gives you some extra information, particularly if you're thinking of applying a ventouse, for example, and you'd see all this amount of caput, you know you're not going to get good application under those circumstances. Next slide. So if you put them all together, station -3, head perineal distance is going to be 54 millimeters or so, and the angular progression less than 120. If it's +2, then the head perineum distance is 25 millimeters, and the angular progression is 130, 140. So it gives you a pretty clear idea as to whether or not you're going to be successful. Carry on. And it does away with any doubt. We can continue on, leave this slide. This is just talking about head direction. So there's 2 or 3 slides, so keep going with those 2. Next one. Next one. Next one. Next one. Next one. Okay. In terms of the assessment of the cervix, this is difficult, but we're getting better at it. So I'm going to skip this if I may. So you will skip the next 6 slides, please. So keep going. Keep going. Keep going. Keep going. This is showing a transvaginal scan. Keep going. So all clinicians report difficulty in assessing the cervix, so I won't linger on that. Keep going. This is cervical dilatation before membrane rupture. As soon as the membrane is ruptured, then it's difficult to work out whether or not there is a rim of cervix or whatever there. Keep going. So we've done some focused studies on the use of intrapartum ultrasound, but particularly, next slide please, is where it's more important. This is slow progress or arrest of labour in the 2nd stage. There's several studies to determine the usefulness of this. So in the occipital position, OA position, head perineal distance less than 35 millimetres, you've got a 2% conversion to caesarean section. A non-occipital position, OA position, head perineal distance greater than 35 millimetres, there's a 35% conversion to caesarean section. If you're looking at head direction and so forth, then upwards direction, 80% spontaneous vaginal delivery rate, 41% head horizontal direction, 20% with downward head traction. So a direction, I beg your pardon. Next slide. I think we can keep going with this. Keep going, next slide. I'm conscious I've lost time. So the 10 most commonly asked questions are, is it easy to do ultrasound? Yes, it is. Next slide. Is it easy to learn? Yes. Next slide. Do you need special experience? No. It's easy to measure. As a matter of fact, there are machines now that measure the angle for you. Next slide. Is it more convenient for the patient? Yes, it takes less than 5 minutes to perform. Next slide. Is 3D ultrasound superior? It makes no difference. You can just use a simple 2D ultrasound, and it's more than sufficient. Does it have a predictive clinical value? Yes, it does, particularly if you're looking at these measurements of 40 millimetres, head perineum distance, angle of progression, 120 degrees or more. Carry on. Next slide. Yes, next slide. Next slide. So the research agenda is important. We need a randomised controlled trial to see whether it does actually lower caesarean section rate and whether or not it addresses the value of intrapartum ultrasound before instrumental delivery. I think we're getting pretty close to getting an answer for that one, and the answer is yes, it does help. Perhaps artificial intelligence can be used in this case where we've got these very strict measurements. Can we carry on again? So we believe that it's quite useful in the conduct of normal labour management and instrumental and operative vaginal delivery. Carry on. And the best predictor is angular progression with head perineal distance and head direction as your next best. Carry on. The place of this is very challenging, but from a midwifery-led hospital obstetric service perspective, dealing with moderate risk patients, intrapartum ultrasound fits with the non-invasive ethos of midwifery care and provides patients and team midwifery members with visual evidence of progress in labour upon which to base management strategies and a collaborative, cooperative cooperation with obstetricians. We conduct hands-on 2-day courses for this for midwives. So in summary, delay or arrest in the late first, second or second stage of labour, these are very helpful. Next slide. And also in the prediction of the potential outcome of operative vaginal delivery. Thank you. Next slide. I just thank the organising committee, of course, my host, Etta Vivian, and her organising committee, and the conference manager, Madison Luna, for allowing us to present our work to you. I'm terribly sorry that there have been so many interruptions. Thank you.
Thank you for your